Neurology quiz number 59. What are the clinical features and management of postural orthostatic tachycardia syndrome or POTS? POTS is a condition characterized by symptomatic orthostatic tachycardia without orthostatic hypotension. It is defined as a symptomatic and sustained heart rate increment of 30 beats per minute or more within 10 minutes of standing, or a head-up tilt in the absence of orthostatic hypotension. Standing heart rate is often 120 per minute or higher. Criteria for POTS include heart rate increases more than 30 beats per minute from supine to standing within 10 minutes. Symptoms worsen with standing and improve with recumbence. Symptoms last more than 6 months. Absence of other overt causes of orthostatic symptoms or tachycardia, such as active bleeding, acute dehydration, medications. Patients are usually young, 15 to 40 years, predominantly female, 80 to 85%. Patients frequently report that the symptoms were precipitated by events such as pregnancy, viral illness, or major surgery. Symptoms of orthostatic intolerance include lightheadedness, dizziness, pre-syncope, changes in vision and hearing, generalized weakness, and cognitive difficulties described as brain fog. In addition, patients have symptoms of sympathetic overactivity, which include palpitations, tremor, sweating, pallor, cold extremities, chest pain, and shortness of breath, as well as nausea and diarrhea. Acrocyanosis may be seen. Some patients experience posturally triggered syncope. Orthostatic headaches may occur. Symptoms are exacerbated by heat, physical exertion, large meals, prolonged recumbency, medications such as vasodilators, and by menstruation. Symptoms are typically relieved by sitting or lying flat. Exercise intolerance is common and the condition can be disabling. Acrocyanosis in POTS. These images show the legs of two patients with POTS immediately after standing up and after standing for several minutes. The reddish-purple discoloration in the legs is clearly seen. POTS can be associated with chronic fatigue syndrome, migraine, fibromyalgia, sleep disturbances, irritable bowel syndrome, and bladder dysfunction. Other associations include diabetes, Ehlers-Danlos syndrome, and autoimmune diseases. Major pathogenetic mechanisms are thought to be impaired sympathetic vasoconstriction in the lower extremities, also called neuropathic POTS, and some of these patients may have associated small fiber neuropathy. Excessive cardiac sympathetic excitatory responses, also called hyperadrenergic POTS, and volume dysregulation and hypovolemia. Evaluation should include measurement of supine and standing blood pressure and heart rate, tilt table testing, cardiac and neurological evaluation to exclude primary cardiac cause of tachycardia and the potentially treatable neurologic causes of autonomic dysfunction. In the hyperadrenergic type, endocrine or other systemic causes of hyperadrenergic state, such as pheochromocytoma, should be excluded. Management aims at improving functional capacity to stand, perform daily activities, and exercise. Fluid intake should be about 2 liters of water or other non-caffeinated beverages per day. Patients may use a bolus of 500 ml of water before anticipated upright activity up to 3 times a day. IV fluids can improve symptoms promptly, but the effect is not long-lasting. A regimen of 1 to 2 liters of normal saline given at a frequency of once per month to twice per week has been reported to reduce symptoms and improve quality of life. Daily sodium intake should be increased aggressively if cardiac or kidney disease does not coexist and ranges from 2 to 8 grams. Thigh-high or waist-high compression stockings can be effective but are limited by patient tolerance. Compression garments covering the abdomen and thighs can be used during the day. Physical counterpressure maneuvers like crossing the legs, bending forward at the waist, and squatting which counteract venous pooling, can be performed at the onset of orthostatic symptoms to increase mean arterial pressure, augment cerebral blood flow, and prevent syncope. Patients should be encouraged to engage in a graduated exercise program. Medications can be considered if the above measures are not successful. Propranolol in low doses of 10 mg 1 to 3 times a day lowers blood pressure and improves orthostatic symptoms and is most helpful in hyperadrenergic POTS. Midodrine causes peripheral vasoconstriction and can be beneficial in neuropathic POTS. Patients should not lie flat for 4 hours after a dose to avoid supine hypertension. Pyridostigmine improves orthostatic tachycardia and can improve chronic symptoms without supine hypertension. Fludrocortisone expands plasma volume by sodium retention, but effects may be transient. Long-term use is limited by risk of renal and cardiac fibrosis. Droxidopa, a prodrug converted to norepinephrine and used for treatment of orthostatic hypotension, has had variable results in POTS. Prognosis. Available data on long-term prognosis shows that significant proportion of patients can improve or return to normal function within 1 to 2 years. However, some studies have shown persistent impairment of quality of life measures.